have been on this task force. One is the director of the Mississippi Department of Public Safety, Mr. Michael Fisher. Want to say a word?
Yes, sir. Just briefly, I'm here on behalf of the governor. I'll be here today. He's out of state. Anybody that hasn't been in a coma for the past 5 years or so knows that we've got a serious problem here in the United States that's become insurmountable. I personally believe that spending 40 years in law enforcement, 32 years in narcotics alone, that we're on the brink of a pandemic with respect to overdose deaths in this country. I've never seen it any worse in my entire career. I worked in street narcotics, buying heroin on the street. Never thought I'd be at the end of my career and we'd be talking about such serious abuse of pharmaceuticals. Governor appointed the task force back in the fall, and I think they've done a stellar job of coming up with some serious recommendations. Like a lot of other things in this country, we've got to start looking at things differently than we've looked at them before. We're never going to arrest our way out of this situation, and we certainly don't want to stand and point fingers at each other. There's no time for that now. It's a multifaceted issue, and I commend the task force for the recommendations they made and support them fully. But I appreciate all y'all being here. This is democracy at its best, and I'm going to sit down now and let you have it. Thank you.
The next one I want to recognize is the director of Mississippi Bureau of Narcotics, Mr. John Dowdy. He's not going to say anything, he's just going to stand back there. Okay, this is going to be crowded and busy and long. So I want to welcome everyone here to the hearing for the discussion of the proposed new changes in rules and regulations pertaining to Section 2640, which is the section of the rules that apply to prescription writings and controlled substances. These rules have not been updated for several years, but due to this opioid problem, which is a national issue, we, the board, have been asked to look at our rules and regulations on this issue and see if things could be changed that would maybe lessen the addiction and death rate in Mississippi due to these opioids. We did rely on information published by the Government Task Force on opioids that was presented this year, and we have members of the task force present. It would be incorrect to state that those practitioners licensed by this board are the total cause of the opioid crisis in our state. But we do know that we are part of the problem. So this is an effort to solve our part. And then we can turn the rest of it over to the DEA, NBN, and other law enforcement agencies because we don't have any control over it. Due to the input from some of you, there have already been some minor changes made to better identify the scope of this section of the rules, and the changes should have already been handed out to you in a bullet point piece of paper at the door. I don't know how many of these we have, but these might not have had enough. These changes to Section 2640 are not the end result yet. We have listened to comments from licensees, hospitals, national and local societies and specialty groups, as well as citizens who are concerned about their health and welfare. Today, we're here to listen to more comments and questions from you. And I will assure you, we're going to listen. And we're going to use this as additional input into these rules and regs. But our object here is to protect the health of the citizens of Mississippi. So it's probably not going to please everybody, but we got the public as our concern. We do want to hear from each of you that are signed in to comment. But to do so, there must be a few rules of the road so everybody will get a listen. Number one, each speaker will have 10 minutes to speak. So try to be concise to the point. When your time is down to 1 minute, Ms. Ross will hold up her hand with a 1. That means you got 1 minute left. So it's time to wrap it up. Number two, when recognized, please stand, come to the microphone, and give your name, title, specialty, and who you represent. We prefer only one speaker per organization, if possible. If possible, give the section and portion of the rule change you would like to address. That way we can all turn to the same page, and they'll speed things up. A board member may decide to ask a question to a speaker, and that won't detract from your 10 minutes. The time will be on hold. Here's one. If you notice that a previous speaker has already brought up your topic, and it's been solved or resolved, please try not to rehash the topic. There are other people with. The Mississippi Board of Medical Licensure derives its authority to make these rules, regulations, and changes concerning the practice of medicine from statute 73-4311 of the Medical Practice Act. Now, when called on, come to the microphone, pick it up, make sure it works, and give us your name. And number one will be Blake Bell, representing the American College of Obstetrics and Gynecology. Sure.
Good afternoon. My name is Blake Bell. Here today representing my client, the American Congress, Mississippi section of the American Congress of OBGYNs. We are the largest specialty society in the group representing the OBGYN community and the patients they serve. It's good today to have some friendly faces on this board, including some of our favorite OBGYNs. And would like to read some statements that our group has put together in reviewing the proposed rules from this board. Dr. Paul Seago intended on being here today. He apologizes. He had a patient issue come up and was not able to attend. To start, Mississippi ACOG recognizes the urgency of this health epidemic, and Mississippi ACOG wants to be part of the solution. Before you adopt these regulations, we would ask that you would allow providers and their concerns to be heard, and an opportunity for those providing care to the patients of the state of Mississippi to provide input and to help better develop the most appropriate language to fit the needs of our community. Mississippi ACOG feels the proposed rule, Part 2640, places an excessive and unrealistic administrative burden on the clinical practice of medicine. Furthermore, Mississippi ACOG believes the proposed changes may have unintended adverse consequences. The specific concerns of Mississippi ACOG include the requirement for all licensees to run a PMP report at each encounter when prescribing opioids for acute and chronic pain is an overriding administrative burden and impractical to accomplish in the care of patients and the practice of clinical medicine. The requirement that the PMP reports be kept in the patient file is a duplication of work and an administrative burden. Placing a PMP in a medical record may have serious legal implications in the future and unintended consequences. Prohibition from prescribing more than a 7-day supply of opioids for acute pain is a vague rule which may have the unintended consequences of physicians prescribing higher counts than usual to avoid callbacks. Many patients take benzodiazepines chronically and may require treatment for acute post-surgical pain and for longer than 7 days. The requirement for informed consent prior to prescribing opioids is vague and again, an administrative burden. Who is to say what constitutes a valid informed consent in these situations? Perhaps the most striking omission in this proposed rule is the apparent lack of concern and compassion for the post-operative patient, and in OBGYN's practice, the obstetrical patient. All of these patients hurt after their surgery and/or procedure. Many, if not most, cannot take non-steroid medications, and others non-opioid methods of pain relief. Many require pain management for longer than 7 days, and opioids have been and will remain the mainstay of management. Mississippi ACOG implores the board to waive any proposed rules for perhaps up to 30 days for the pain management of post-operative and obstetrical patients. Opioid prescriptions for acute post-operative pain are written at inpatient or outpatient surgical centers and are recorded in the facility record. Requiring the physician to maintain an office PMP report for each of these prescriptions is an impractical and unreasonable administrative burden. The requirement that physicians generate a global PMP report each year is a duplication of work and burdensome. The PMP information is already available to the Board of Medical Licensure for review. Proposed Rule Part 2640 is a legal document that is detailed, but imprecise and in many ways quite vague. As a legal document, it will likely be open to many differing legal opinions, making compliance difficult, if not impossible. Physicians are not lawyers. Physicians take care of patients, and administrative burdens from many sources make physicians' jobs more difficult. As these are rules for physicians, Mississippi ACOG implores you to simplify the document rather than making it more complex. In summary, these proposed rules will place a significant administrative burden on medical practices, especially those providing acute surgical services, and will be a significant impediment to providing the care of our patients. It is likely that OBGYNs may simply refuse to prescribe opioids, even for patients who really need them. Mississippi ACOG fears a public outcry should these rules be implemented in the proposed forms. In closing, we ask the Board of Medical Licensure that you have a more thorough dialogue with providers who are concerned with the unintended consequences that were proposed through these regulations, and that will be placed on the ability for OBGYNs to care for their patients. Mississippi ACOG wants to be part of the solution and is willing to provide insight into how our specialty can deliver the highest quality care to the patients OBGYNs serve. Thank you for allowing us to comment today, and we hope that you take these comments into consideration and hope to be able to provide additional feedback to this board moving forward.
Thanks, Mr. Bell. Two things. I'd like to recognize the court reporter, Kathy White, that's over there, and she's did a good job. And please silence all your handheld, portable, electronic devices. Nintendos.
In the interest of time, because this is going to be a reoccurring theme, is the rules and regulations do not state that you have to put a copy of the PMP in the chart. It says you can put it in the chart or you can refer to it in your dictation, number one. Number two, we have an exception on acute pain. If someone is on benzos chronically and they have an acute fracture, surgery, they may stay on benzos and opioids for a short period of time. Okay, there's an exception in there. And thirdly of all, we do allow for a 14-day supply, up to a 7-day supply with a refill on that. So you are looking at, if you're talking about post-operative pain, you can get up to 14 days after the surgery. And again, these comments aren't meant to be argumentative, they're just, we're going to explain them as we go through so we won't have a recurrent question. Okay, thank you.
Our next speaker is Dr. Jeff Burns from the Board of Health of South Mississippi. And I'm assuming everybody in the room has read what we've written on it. They've read 2640.
Assuming that.
Dr. Burns. You read it, didn't you?
Working.
That's okay.
So my name is Jeff Burns. I'm an orthopedic surgeon from Hattiesburg, Mississippi. I have fellowship training for joint replacement. I'm a board member on Hub Health, which is a large organization centered in Hattiesburg. We had our annual meeting last night. We represent about 240 physicians and other providers. Just want to tell you, again, I do total joint replacements. I think total knee replacement surgery is by far one of the most painful orthopedic surgeons a patient can have. These patients require adequate pain control for extended periods of time in order to go to physical therapy and get their range of motion back. I do not think a 2-week limit on acute pain for pain medication is going to work for most of these patients. Occasionally there are some that can do better, but most of them easily go 6 to 8 weeks, and even then, they still may be taking 1 or 2 pain pills a day to do their physical therapy and be able to get to sleep. My partner does rotator cuff surgery and total shoulder surgery. He has the same experience with his patients. He would claim and argue that total shoulder surgery or rotator cuff surgery is more painful than knee replacement. So we have several very select patients that do have pain for longer than 2 weeks. If you can't do your therapy and you can't get your motion back, you're going to have a joint that you're going to have to live with the rest of your life. And for whatever reason, it seems as though some patients who have to live with it for a longer time have more difficulty tolerating pain than some of the older patients. So that's kind of my personal perspective right off the bat. I would agree with the other gentleman who just spoke about all of the requirements, and I would recommend that some of these proposals be delayed. Obviously, we know that this is not a new problem. This has been 15 to 20 years in the making. We've had several, it has. So, when I went through my training 15 years ago, pain became the fifth vital sign, and we were pushed to prescribe additional narcotic pain medication because we were not adequately controlling pain. And that is the training that a lot of us have gone through. Now, here we are trying to reverse all that, and we're going to have to change all that. I've been in another meeting with the hospital about a month and a half ago, and there was a lot of anger, a lot of anxiety. I think a lot of it has to do with how are we going to take care of these patients, but a lot of it also has to do with how are these rules and regulations going to affect us, are we going to be in violation. There's just a lot of concern. And in terms of reading the requirements, I went on the website today, and to be honest with you, I had a lot of difficulty even finding what the proposed changes are on the main website. I just don't know why you don't have that on the home page, clear view. So we had Mr. Dowdy at our medical staff meeting, and the different articles that I read in the paper, and even having him there, it seems to me that most people probably know what the problem is. And he went through about 10 to 15 minutes of what the problem is, stating a lot of statistics about narcotic usage and prescription. I think most of the physicians that I deal with on a daily basis will tell you that we have a very small number of providers who are running pill mills. And I don't know why it's so hard for everyone to seem to use that term. I haven't seen it really stated in the newspaper, I haven't heard it on the news, but I think most of the physicians I work with would agree that that is the problem. So the interesting thing was, we asked the question, if this is the problem, have the data on the PMP site, go investigate these individuals. Unfortunately, that's not possible. The response that we got was that there's no legal authority to investigating any of that information, that we should call and report the evidence. So that's a concern that many physicians at that meeting expressed. And we had this other meeting last night, and we had the same concerns. I guess there are some questions that I think really need to be answered. One is, what is the problem, or who is the problem? I'm sure there are physicians that are outliers. If you knew who the outliers were, that seems to me that would be a good place to start. So maybe the better question is, who is the problem? Then I guess the question is, how are the proposed changes going to fix those problems? Just as the other person spoke, requirements on me to check for a PNP site on somebody who had surgery 2 weeks ago really shouldn't change what I do. I should still treat my patient and get them through this knee replacement. So that I think needs to be a big question, is how is this going to fix the problem? The other question obviously is, what are going to be the unintended consequences? And I think there are going to be a lot of those. I think, where are these patients going to go? They can't. The ones who do have addiction problems, where are they going to go if they can't go to their regular family doctor or whoever they can get? Obviously, that's a problem. Are they going to go to the street? Has that been discussed? How is that even going to be handled? Are the number of ER visits going to go up? Is that going to be a problem? The ER physicians at the last meeting expressed concerns that these patients are going to be increased and they're going to have to deal with them. They have concerns that their HCAP scores, which are tied to reimbursements, are going to be negatively affected. And so they're concerned they're going to have a negative reimbursement because their patient satisfaction scores are not going to be adequate. And maybe that's not a valid concern, but that is the concern that was brought up at one of our meetings. The other concerns that we had, I spoke to some physicians last night. I've got a family practice doctor who's got a patient who's got COPD, apparently a lot of anxiety. He has concerns, is he still going to be able to write this patient benzodiazepines? I had another family physician who's treating an elderly patient with vertebral fracture. I don't know if any of y'all have had a vertebral fracture, but they hurt. And they can hurt up to a year. And they're very painful. So his concern is, how am I going to treat this patient? It's non-cancer pain. But how does this all fit in there? And, I know these are a lot of questions, and maybe the answers are out there. But these are all highly educated people, and for whatever reason, they don't have these answers. And so maybe there's just a lack of clear direction on where we can get these answers. And maybe that's the problem. And maybe that would solve a lot of the anger and the anxiety that a lot of these physicians that I speak with on a weekly basis are dealing with. So I have a lot of other things here dealing with the PNP site. If we truly do not have to provide a copy of that and have that in the chart, that is a wonderful development, because that would be burdensome. I think most of us treat patients individually, and that's what we go through medical school. Everybody's not the same. And so I think most of us probably do it on a patient-by-patient basis, determine which patients we can tell are going to be problematic and which aren't. And you do the PNP side. A lot of questions have been brought up regarding the urine drug screen. How is that going to be? Do we have any kind of guarantee that if you do a urine drug screen, it's going to be covered by the insurance company? I think that's an issue for a lot of them. I don't typically do urine drug screens, but some of these that do have concerns. I think it's also interesting to note that there have been several papers, articles in the paper regarding the involvement of large drug companies. I thought it was interesting in the local newspaper that the USA Today section had a large section with Governor Christie being named part of the task force for Trump. And by God, he's going to have the CEOs of the pharmaceutical companies involved in this whole process. So I guess the question is going to be, what new medications are they going to come out with that can help patients get over these addiction problems so they can make more money? I just find it really funny that of all the people that he could have had at that meeting, it wasn't physicians, not even from the large hospitals. Nobody, not even from the medical school in New Jersey. He's meeting with the CEOs of the pharmaceutical companies. And so I think that, creates a lot of anger too, that the underlying problem is bigger. And how do we fix that? And I thank you for your time, and I hope this will be productive.
Thank you. Our next speaker is Dr. Susan Buttress, from the American Academy of Pediatrics. Good afternoon, Susan.
Good afternoon. First of all, I'd like to applaud you all, the board, for taking this on. It's a really, really difficult task. We know it's something that needs to be addressed, as our other two speakers said. We know it's a very difficult task, and trying to figure out something to do is important. I don't think we needed to leave it alone. With that said, I received comments from several pediatricians across the state with some concerns, not specifically about the opioid, though there were a couple of neurologists who were concerned about the 7-day supply, but also about ADHD medicines. And part of that, on item 5, licensees are bound by new guidelines for prescribing any controlled substance. That's on page 25. At the top, those licenses who practice is not pain management. All patients who are prescribed, administered, dispense controlled substances. So, of course, that means any stimulant medication. Every private practice and public practice pediatrician in the state prescribes some stimulant medication. And also, many of these children, it's a chronic disease, ADHD, attention deficit hyperactivity disorder. It occurs, supposed to occur in about 5 to 7% of the population. And so that's a fair number of children in our state who may or may not need medication. With that said, yes, there may be some over-prescribing in some areas, but the reality is if you're changing a child's medication and you can only give a new medication controlled substance for 7 days, then what happens to the number of prescriptions that child is able to receive? It increases the copay if it's an insurance patient. It diminishes the number of prescriptions that a Medicaid patient can have. I know that was an unintended consequence, but if a child has a trial of a medication, a stimulant medication, then we typically say it needs to be a 2-week trial rather than a 7-day trial. And with that said, most of us who treat ADHD are pretty adept at now choosing a medication that's appropriate for that child to start. We typically start low dose. We like to go for at least 30 days and then increase up, or if we need to increase, give instructions with a 30-day supply and how that can be done. So that's one big consideration and concern, that the limitation on that 7-day supply is very difficult. There were some concerns about the PNP, but I won't even address that because it sounds like that's been changed somewhat. The other issue, and maybe you can clarify this for us, the way we felt that things read is prescriptions may not be written outside a valid licensee-patient relationship. So does that mean that if a child, your patient, and you're on medication, another physician cannot write that prescription? That's what it sounds like in the rules, which would be very difficult since these children, most of them are at least on medications during their school year if they happen to take a break in the summer. Again, I think another unintended consequence of what perhaps you meant to say in this, the American Academy of Pediatrics has a very strong practice guideline that was just revised on how ADHD should be treated. And these rules would not allow us to treat it at the recommendations that are outlined by the AAP. And then if I might address besides the cost, the time spent for physicians to have to go back and forth with giving prescriptions to patients, it also diminishes the number of visits. It increases the number of visits that will be required for ADHD patients, and therefore they will use up the number of visits that are allowed with Medicaid. 65% of children are on Medicaid instead. 65%. So we're talking about increasing a financial burden to our state because then people have to write plan of cares or necessity plans so that visits can be increased. And then finally, if I might just address something that our neurologists were really concerned about, and that is patients who are treated for spasticity with benzodiazepines. Many times, if they have significant spasticity, they get a new prescription. A 7-day trial is, again, typically not length of time that one would want to use for the treatment of the spasticity in these children. So Ativan is also often used in seizure control, and so that's another issue that has come to pass as one of those concerns that the pediatricians around the state have had. But again, the major issue is it will cause an unbelievable burden for the pediatricians in the state. And I'm afraid some will start refusing to treat ADHD. We already don't have enough people who take care of our children with developmental behavioral needs. We hope to fix that one day, but right now we're in short supply, and so we are hoping that this particular will be addressed. And I'd be happy, I'll offer to help in any way if you would like any input from the Academy. I am very, very aware of appropriate practices for ADHD treatment. I teach it across the nation, and I'd be happy to help in any way. So again, I want to thank you. I know we need to address it. I think everybody in this room knows that we need to address it. We just hope, we know you're listening because you're sitting there. So we hope perhaps some changes will be made to these guidelines that will make it a bit easier. Thank you.
In an effort to, again, further clarify, because it's going to be a recurring thing, the only reference to 7 days is license that I'm aware of. Licenses are discouraged from prescribing or dispensing more than a 3-day supply of opioids for acute non-cancer pain and must not provide greater than a 7-day supply for acute non-cancer pain. Bottom of page 11 does not pertain to ADHD treatment. Now you have to run a PMP every 90 days on those. You see them every 90 days, and you only have to see them every 90 days because you can give refills on ADHD issues. You know how to do that. We need to clarify the partner covering. Obviously, if you're a partner of a physician and that physician's out of town, certainly you can do what we've always done, which is cover that practice, so we can clarify that. And if you could please, Susan, get to us the new recommendation from the American Academy of Pediatrics on treatment of ADHD and how this affects that treatment. Because again, we're not talking about 7 days. That doesn't apply.
That clarifies that. And I think that, yeah, the biggest concern that some practices, once a patient's stable on medication, sees them every 6 months rather than every 3. They're very busy practices. I respect your decision on that, but that is one other issue that the pediatricians, especially in northern part of the state, are concerned.
The other thing is there's no limit on there's not a 7-day limit on benzos for spasticity treatment, so.
Is that written in there? I'm
The
sorry.
only
Is
reference
that
to
listed?
7 days is for opioids
It's
for
for
acute.
opioids, and so they don't need treatments or surgery like that. Thank you.
Thank you. Next speaker is Dr. Samuel Crosby from the Mississippi Oncology Society.
David Morris, individual from the Mississippi Oncology Society, Dr. Crosby. We're both in that clinic.
Okay, then you each get 5 minutes. Any way you want.
Society is employed by the same group.
That says the Mississippi Oncology Society. Is that two societies?
No, Mississippi Oncology Society is one, Hattiesburg Clinic would be the other.
We both work at the clinic, got sitting together, somehow my name got put under one, is that it?
Our same person, same contact forwarded both of our names.
I knew this would happen.
Yeah. Oh, okay, we might be able to get it done in time.
Let's hope.
I'm
We're
David
gonna be here
Morris.
till 7 o'clock anyway.
I'm David Morris, I'm the president of the Mississippi Oncology Society. The understanding that many people have had throughout the state, particularly the non-cancer providers, is that this is not intended to affect our cancer patients, and we don't believe it has. Looking at it though, I've gotten a lot of feedback that the wording through the proposed, amendments in legislation does not adequately cover what we need to do as cancer providers. So we would like to be able to strengthen the language so that specifically for our cancer patients, that there's some issues that might not come up. Number one would be the absence of a definition of cancer-associated pain in the contract. Of all the definitions, that's not one that I noticed in the contract. And it makes it confusing as cancer providers because many of our patients have pain related to treatment for potentially curative cancer. A lot of the stage 4A head and neck cancer patients are potentially curative. It's localized adenopathies that require some aggressive treatment, chemo and radiation. And so we would like a definition that does include aspects of both acute and chronic pain related to malignancy, either directly related to the malignancy or indirectly from diagnostic testing and treatment for the malignancy. So that would certainly alleviate a lot of the concerns and a lot of potentially the misunderstanding of cancer providers, because many people are afraid to treat patients appropriately. We do have plenty of data that shows that cure rates and life expectancies are diminished if we're not able to complete treatment uninterrupted, if we're having to take away so people can heal up and then restarting. Outcomes just are not as good. And even though that's not the intended point, from my understanding from the board, that could always be reinterpreted down the line, or it may be misunderstood by the provider, so that definition would help. I did notice when I came in, I was given a piece of paper that said one thing that was intended, it was to change the term non-cancer to non-terminal, but I actually think they're two different entities, and because of those reasons, but also the terminal diagnosis that's included in this is for life expectancy of 6 months or less. We may have patients who have a life expectancy of 6 months or less without treatment. They may come primarily manifesting bone pain or metastases to the bone, but they don't have spread to the liver, lungs, other organs, and they may be able to maintain a good quality of life, and their life expectancy may be 14 months with aggressive treatment, 10 to 14 months. That's an average too. We have people that do better, people that don't. So we don't need to take away, have people not pursuing treatment that may be beneficial because of that. And I don't think that, once again, not the intention, but I guess Rule 1.7 that deals with chronic non-terminal pain, if we could perhaps change the language to where it said chronic non-cancer related non-terminal pain, that would certainly solve a lot of these issues pretty simply by adding a definition of what cancer-related pain is, and then amending that section so it's meant to include chronic non-terminal non-cancer related pain. Other aspects of concern. Within 1.7, the reason that's important, I guess there are a few things. We actually do require benzos for many of our patients in conjunction with opioids for different reasons. We have people that get anticipatory nausea where they start throwing up the morning they get their chemo before they arrive at the office. And benzos are pretty much the most effective treatment for that. We have patients who have air clear. We have patients who have claustrophobia related to the radiation treatments and other diagnostic testing. And to be able to use those medicines in conjunction is certainly necessary sometimes. The requirement to refer our patients to pain management providers that they're on more than 100 morphine equivalents is just not reasonable for a number of ways. We actually see everybody. We have somebody that's uninsured or underinsured. That's not somebody that we can wait however many weeks or months to get in with a pain management provider. We may be limited on what volume pain management providers can handle. We have some that won't treat cancer-associated pain. And quite honestly, we feel like we do a better job of knowing what is expected as far as the treatment goes and evaluating the patient and managing their pain appropriately for the situation. So if we could just change that one section to non-cancer related, non-terminal, those issues become not an issue in those patients. And it would certainly relieve a lot of the concern. It has felt like let me just go back a second. We do not want to be the gateway for the state to send everybody with a cancer history to our office to be out prescribing, and that's not what this language would do. But it's also not what we want. If it is felt by the board that we need to incorporate down the line, and feel like that is a weak aspect, we'd be happy to work with y'all on a committee level to address any concerns related to cancer-related pain. But we do know if this policy is designed to affect outcomes in our state, then we need to be able to manage our cancer patients appropriately so that the overall well-being and outcomes with regards to that are there. As somebody who had to take off time and many cancer patients on pain medications, the last concern is I had bypass surgery last year. I was not able to continue writing my patients their pain medications, and in my absence, my partners were able to. So I guess the clarification on Rule 1.11 would just make sure that we are able for our partners to provide in our absence for those patients too. That would summarize the main concerns. And once again, we're happy to work with y'all with any specific concerns that may arise with changing this. We think we might be better served to bring up the points in our patient's management that need to be addressed.
We thought we had done this here by terminal disease pain should not be confused with chronic pain.
Yeah, but I think terminal disease is inadequate. We do have people that have life expectancies greater than 6 months. We have people that are potentially curative that need more freedom, although their treatment may be intense over a time frame. So I think the terminal disease pain, I think changing non-cancer to non-terminal would only make this worse for what we need to do. I think you should incorporate both as far as non-cancer / non-terminal pain. We don't go applicable, but certainly by adding a definition in 1.2 as far as defining cancer-related pain, and I should have a copy of what I suggest. It's in the freeze, and if not, I'd be happy to send it back.
The reason we went from non-cancer to non-terminal was because of the 40% of hospice patients that don't have cancer.
Right.
It may need it, but I certainly think it's appropriate to add both of those. And if someone's got cancer, we have no interest in it.
Yeah, and we didn't understand that because, just making sure
So
we
that's a
get it
good
right.
suggestion.
That would be good. The remainder.
I can call quick when I need to. I'm Sammy Cross, I'm a family practice doctor representing Hattiesburg Clinic, as well as 500,000 patients in our surface area, about 1 million encounters a year we have. So we touch a lot of people. More specifically, I'm actually representing also, chair our quality subcommittee on controlled substances. We've been addressing this issue for several years now, aggressively. We brought in a pain management specialist. We've identified our list of providers and all the patients on controlled substances, on combinations. We're aggressively going after that and treating that ourselves. Now our EMR actually has a header. Every time you see a patient, it tells you in the header how much morphine equivalents each patient's on every patient program they're there for. And we think that's a great idea. It brings attention to it, and our guys are responding to that. We actually have a protocol that very limited, the same thing y'all have brought forward on our protocol, which we were ready to kick off a couple of months ago. But when we heard these rules were coming out, we didn't want to bring ours out and have to change them. 2 months later. So many of the same areas, we're hitting the same areas all are. But there are a couple areas we want to address. Rule 1.3, bottom of page 24, and top of page 25, where it does talk about acute pain. And that's how it's come up several times today. It's well established, the real issue today is Schedule II opioids. All the top 10 drugs of abuse and opioids are all Schedule II, they're not Schedule III. We would request to consider, if there's gonna be a requirement to check the PMP for acute pain, it'd be for Schedule II opioids, that seems reasonable. If we're gonna be limited to 3 to 7 days anyway, Schedule III or below, we think that's a little more burdensome than is necessary. The Schedule II is where the problem is. I got 1 minute. Pain management consultants, you got the one in the back. The section on that on Rule 1.7, we want to make sure and clarify that with limited access to pain management specialists, that we expand that, or y'all recognize that that would include the nurse practitioners and PAs working with them and not have to be with that guy up front, because we now go to a 30% trigger for what's pain management practice. A lot more people won't have to go through 100 hours of CME training or whatever to be qualified. I did that, but a lot of people won't. Got 45 seconds. Rule 1.1 and 1.14A, both have to do with benzodiazepines. If you look in those definitions where it talks about what a pain management practice is or clinic does, it lists the opioids and barbiturates and everything else involved, it lists benzodiazepines. Benzodiazepines are not treatment for chronic pain. Okay, so we would suggest that that be separated. We are all for checking PMPs for benzos, we have no problem with that. But if they're only on benzos, doing a drug screen every 90 days seems a little over the top. And almost in closing, concurrent benzos, Rule 1.7, page 35. We recognize the CDC guideline number 11 and the government task force recommendation number 16. Both note the commission should avoid when possible or strongly discourage doing opioids and benzos together. But these guidelines, those suggestions are not absolute, as Rule 1.7 would suggest. Our committee reviewed the literature, and we came up with noting that that guideline is Category A, Evidence 3, which means it's our professional study with notable limitations. That's not evidence-based, that means there's a problem there, notable limitations to this study. We came up with the idea that if you keep the benzos low and you keep the opioids low, that seems reasonable. And we'll be glad to expand on that and what our committee came up with. The documentation issue has been already addressed. We would like to know if documentation simply matter that it's been stamped, or do we actually have to dictate what the report said, or just we reject it, and that satisfies it, that's fine. Other things I can let go.
Thank you.
I got more, but I
I apologize for that.
no.